Hi, everyone. This is our monthly resident in-service for spinal cord injury topics. This month, Dr. Emily Hahn is going to be talking about pregnancy in individuals with spinal cord injury. This is a really interesting and critical topic, and it really shows how rehabilitation providers can really be useful to patients in all phases of pregnancy, from planning to delivery to following pregnancy. How do they care for their babies? So with that, Emily, I'll pass it over. Just also note this will be recorded and available to our therapists and other providers on YouTube.
Awesome, thank you. So once again, my name is Emily. I'm a PGY2. I'm responsible for this month's spinal cord injury talk. And today we'll be focusing on pregnancy with spinal cord injury. And thank you to Dr. Abramov, who gave me resources and gave me this time to talk about it. So I wanted to start by taking a step back for a second. So just looking at the numbers, nearly 300,000 people with spinal cord injury live in the US alone. And each year there are more than 17,000 new spinal cord injury cases. And about 20% of these new cases are female. So among this female group, adolescents are one of the age groups that are most likely to have spinal cord injury. And in case you're wondering, the other group of female patients that's most affected by spinal cord injury are females aged 60 plus. But regardless, there remains a sizable population of the female spinal cord injury patients who are of childbearing age when their injury occurs. So the question is, can they become pregnant, conceive, and then have families after spinal cord injury? And based on the name of my talk, the answer is yes, they absolutely can. And one study found that 14% of women had at least one conception after their injury. So as far as the fetus itself, studies have found that the rates of stillbirths, congenital malformations of the fetus, and preterm births are equal in women with spinal cord injury compared to the general population, which is great news. However, there are certain risks and considerations that this population faces just by nature of the fact that they do have a spinal cord injury. So their care teams need to be aware of these risks, should discuss them with the patient and address them during the course of pregnancy. So the best thing to do, ideally, these women with spinal cord injury who do wish to conceive should be speaking to their multidisciplinary team prior to becoming pregnant, and that's going to help just with the planning. In terms of what we'll be focusing on for a large portion of our talk, we'll be looking at pregnancy-related complications in women with spinal cord injury. So the first one, the most important one, is autonomic dysreflexia, or AD. So autonomic dysreflexia could be a talk all on its own, but I just wanted to touch on here, look for things that we might be seeing in this patient population. So autonomic dysreflexia it can occur in patients with spinal cord injury who have a level of injury at T6 or above. And the risk is higher in patients with complete spinal cord injury versus incomplete spinal cord injury. And it can first occur 2 to 4 weeks post-injury. So what exactly is happening? So there is some noxious trigger stimulus below the level of spinal cord injury that then induces an uncontrolled sympathetic response. And this will lead to a response to that via the carotid and aortic baroreceptors. So there are going to be signals sent to the brainstem that will attempt to address the blood pressure that's now increased due to the sympathetic response. The body will try to address this with peripheral vasodilation. Something else that's happening at the same time is that there is an increase in vagal parasympathetic drive to the heart, and this will lead to some relative bradycardia. So what should we as providers be looking for? Well, the patient may be complaining of headache, blurred vision, nasal congestion. We might be seeing them flushing, sweating. This is above the level of the spinal cord injury. And we will also see on vital signs the relative bradycardia that we just discussed. Below the level of the lesion, we're going to be seeing hypertension, pallor, cool skin. And in this particular population, it's important to control because it can be life-threatening. It can lead to maternal intracranial bleeding, fetal bradycardia. So it's really important to stay on top of this, to be vigilant for symptoms that might suggest that AD is underway. So the next category of complications I wanted to talk about was bowel and
Emily,
bladder. Yes.
can I ask some questions?
Yes.
So if somebody comes to you and they have autonomic dysreflexia, and let's say they're in their third trimester, late third trimester, what are your thoughts? What are your kind of considerations?
I am glad that you asked that. I was going to touch on this a little bit later.
Okay, all right. If you're going to touch on it, we can wait.
No, it's okay. You already asked the question, so other people will be wondering too. So in a person who's in their late third trimester presenting with signs that might be consistent with autonomic dysreflexia, that could actually be the first sign that the patient is in labor. So that's something to definitely keep in mind when they're late in their pregnancy. Any other questions relating to this since we were touching on it now?
What else could it be besides labor?
So in the pregnant population, there is the possibility of preeclampsia or eclampsia. This can also present with high blood pressure, which might make us think at first with this population about autonomic dysreflexia. However, the autonomic dysreflexia that is concurrent with labor, that's the autonomic dysreflexia that's being due to the contractions, which would be the noxious stimulus in this case, the blood pressure will rise and fall in the same pattern as contractions, which would be one clue that we would be dealing with autonomic dysreflexia and not eclampsia or preeclampsia.
And then what else besides pregnant, like labor issues?
High blood pressure, you're saying? Or what was the question?
Autonomic dysreflexia, just kind of outside of the labor issues.
I mean, autonomic dysreflexia could be caused by a lot of different things in the spinal cord injury population. And what I was next going to talk about is urinary retention and constipation. So those are really important to keep on top of within any spinal cord injury patient, but especially within the pregnant population.
Mm-hmm. Great, go ahead.
Okay. So that leads us right into what I was going to talk about next, complications relating to bowel and bladder. So first we can look at the bladder. Complications relating to that with pregnancy and spinal cord injury patients is that in pregnancy, urinary incontinence can be aggravated. And then on top of that, there's the increased risk of developing UTIs. So UTIs were reported in 45.5% of pregnant patients with spinal cord injury, and that's compared to 8.2% in pregnant patients without spinal cord injury. Why is there this increase in risk? So it could be related to a couple of different things. It could be due to incomplete emptying of the bladder, neurogenic bladder, and then catheterization. So interestingly, or I thought it was interesting, there was one meta-analysis that found that 100% of patients with permanent catheters developed UTIs, and that's compared to 38.5% in patients who self-cathed, and 53.3% of women who were able to avoid spontaneously. As providers, we really should not be prescribing antibiotics unless the patient developed pyuria or pyelonephritis. And then on the other hand, when we look at bowels, both spinal cord injury and pregnancy are both independently associated with constipation. So as providers, what we can do is encourage them to have a diet high in fiber, encourage timed bowel movements, laxative use, and digital stimulation where appropriate. And this is all to try to maintain proper bowel care. And like we mentioned before, urinary retention and constipation are common causes of autonomic dysreflexia. Okay, so the next category of complications I wanted to touch on are thromboembolic ones. So we know that in the general pregnant population, these patients are in a hypercoagulable state. So is there increased risk of a thromboembolic event in a pregnant patient with spinal cord injury? So we do know that there's an increased risk of thromboembolic events in the first 6 months after spinal cord injury, but the risk after that is equal to that of the general population. So why does that risk change? There's the thought that there is vessel remodeling and physiologic changes below the level of spinal cord injury that contribute to the change in risk. So as of right now, there are no universal recommendations for DVT chemoprophylaxis in patients with spinal cord injury who are pregnant. There are, however, some healthcare centers that use low molecular weight heparin in their patients, but this is not standard of care at this time. Okay, next we can talk about respiratory complications. So patients with spinal cord injury above the level of T4 may have partial or complete paralysis of respiratory muscles. So as pregnancy progresses, respiratory function can worsen, and this may lead to the need for things like respiratory exercises, CPAP machines, and even mechanical ventilations. So at each antenatal visit, the patient's respiratory function should be measured. And in particular, we should be looking at a patient's vital capacity. So I have this graphic to the right of the slide. The x-axis is time as an individual is breathing normally when they have this, oh, you can see my mouse, a forced inspiration and then a forced exhalation and then returning to normal breathing. The y-axis is the lung volume at that time. So vital capacity is defined as the total amount of air exhaled after a maximum exhalation. So graphically, it is the sum of the tidal volume, which would be this area of the graph here, plus the inspiratory reserve volume, which is this area right up here to this peak, plus the expiratory reserve volume, which is this area right here. So in summary, graphically, that the vital capacity is from this peak to this trough. So what exactly are we looking for when we're looking at vital capacity in these patients? So we're trying to see if the vital capacity is less than 12 to 15 milliliters per kilogram. And this would tell us that this patient needs to be on mechanical ventilation. Okay, so the next area of complications we can talk about are the cardiovascular ones. So the patient ideally would have seen their provider before embarking on conception and pregnancy. So ideally they would have baseline blood pressure and heart rate values to compare to when they are pregnant and at each antenatal visit. So of note, for women with tetraplegia, it is common for them to be hypotensive. Being in the 80s over 50s is perfectly normal for them. And a lot of patients can be bradycardic at baseline. So they could be 40 to 50 beats per minute. And that is, again, perfectly normal for them. So what, as providers, we need to be on the lookout for are changes in systolic pressure of 20 to 40 millimeters of mercury above the patient's baseline. And that would be concerning for autonomic dysreflexia, or as we touched upon earlier, initiation of labor, and actually both at the same time. Okay, next we can talk about skin complications in these patients. So there was a study that noted that decubitus ulcers occurred in 6% of pregnant patients with spinal cord injury. So why is there this increased risk? It could be due to a couple of different things. It could be due to weight gain, tissue edema, and immobilization during surgery. So it's really important at each antenatal visit to do really thorough skin checks on these patients to monitor skin and developing wounds. So as providers, we can really encourage patients to turn every 2 hours and to use pressure relieving mattresses to try to minimize that risk. Okay, next, something that can occur within this patient population is worsening spasticity. So there was one study that found that pregnancy increased spasticity in 12% of pregnant patients with spinal cord injury. So ideally, spasticity treatment during pregnancy would be done via an intrathecal baclofen pump. So this medication would be released directly into the cerebral spinal fluid and would not expose the fetus to this medication. Oral baclofen has been shown to lead to neonatal baclofen withdrawal symptoms, so that is discouraged. However, if a patient does not have an intrathecal baclofen pump, the next line agent would be diazepam. And if the patient is specifically complaining or is symptomatic of bladder spasms, oxybutynin can be used. So of note, in patients with spinal cord injury above the level of T10, an increase in spasticity may be the first sign of labor. So really important to follow up on that. Okay, next we're going to be talking about delivery and labor itself. So there are essentially two different experiences that a pregnant woman with spinal cord injury could have, and that is determined by the level of injury. So patients with spinal cord injury below the level of T10 will be able to feel uterine contractions. So uterine contractions are transmitted via the Frankenhauser's plexus, and then they enter the spinal cord at the T10 level. And that's why the T10 level is really so important, and that's where the dividing point is. In patients with spinal cord injury above the level of T10, the initiation of labor could present as a couple of different things. Some of them we've already talked about. Could present as autonomic dysreflexia, hot flashes, increased spasticity, or none of the above. So patients can be taught to palpate fetal movements and contractions to help with this. So pregnant patients with spinal cord injury should plan to have a vaginal delivery. Now, there are special considerations that may have to occur. It is recommended that these patients have an indwelling catheter placed, if there's not one already placed, and that they have early epidural analgesia with a block target of T8 to T10 as soon as possible, and that's recommended in order to prevent autonomic dysreflexia in the susceptible patients, meaning patients with spinal cord injury above T6. Now, cesarean sections should only be done if it's indicated from an obstetric perspective. And I thought this was a little interesting, but of note, there is a higher frequency of breech or transverse lie presentations in pregnant women with spinal cord injury, especially in women with spinal cord injury above T10. So for those of you who needed or would be helpful for a graphic reminder, I have this graphic up top on the upper right. So breech presentation is when the fetus's head is basically directly opposite from the cervix and the vagina. Transverse lie is when is kind of in between the vertex and the breech presentations. Why do we have this higher frequency of breech and transverse lie presentations? It's thought to be due to reduced muscle tone in abdominal muscles. So a patient who presents with breech or transverse lie fetal orientation do not necessarily need to jump immediately to cesarean section. External cephalic version can be attempted to correctly position the fetus. Okay. So we talked about a lot of potentially scary complications that could occur with pregnancy, but women who have had children after spinal cord injury have anecdotally reported improved quality of life thereafter. So with a dedicated multidisciplinary team, pregnancy can be safe and delivery can be safe. So they absolutely can have a family if they choose after spinal cord injury. Okay, these are the references that I use primarily for this talk. And thank you so much for listening. If anyone has any questions, I'm happy to answer them now or have a discussion now.
Hey, Emily, really excellent talk. I thought it was very thorough, comprehensive, and just an interesting topic, not one that certainly I had thought too much about just because, I never had an exposure to a pregnant patient on any of my SCI services. I had a question in regards to, the actual process of the delivery of the baby. Have you come across any research talking about whether the contractions of the uterus are perhaps affected in a case of a complete spinal cord injury if labor is prolonged because of that? Just wondering if you can.
Yeah. So my understanding is that the uterus contractions are not affected by the spinal cord injury at all. So as far as I am aware, labor should proceed as with any other woman in labor. Great question.
Emily, did you? Emily, did you comment on postpartum mortality with spinal cord, or did you read anything about that?
So I did not see anything about mortality. I assume you're returning to the patient, the mother. So
yeah.
It's interesting. There is literature that does show us that that women who go into labor who have spinal cord injury, they're more likely to have a cesarean section. I don't think it has anything to do with about concern for any mortality of the mother. I do think, though, that it reflects maybe perhaps some lack of understanding or just a lack of confidence maybe in the obstetricians who are dealing with this population, because I think it's not common to have a patient with spinal cord injury who does become pregnant.
Any thoughts? Oh, first off, excellent presentation. That was really thorough. I thought you did a really great job kind of introducing everybody to the concepts. So thank you for that. A couple questions that I have. Any thoughts on therapy or therapy considerations?
So I think that a pregnant spinal cord injury patient will be more prone to being immobile. So that's something that they can work on with therapy. And that will help also with the potential skin complications that might arise. I think pelvic floor exercises might be helpful in this population. Beyond that, I'm not quite sure.
Yeah, I mean, I think that's good instinct. You know, a lot of these patients, one, obviously, like mobility transfers, equipment needs might change. They might need to learn how to catheterize differently or use new mirrors or have lifts and things like that they hadn't used before, and they have to learn how to use those things. And really, your occupational therapist can be really helpful in terms of like practicing caring for a newborn. You know, things like getting in and out of the bassinet might be a little bit different, or swaddling. And don't forget, we have patients that have tetraplegia too. So even holding their baby or feeding their baby can be really challenging, and using adaptive equipment and practicing with like even dolls and things like that before the baby comes can be really important so that they don't get, you know, have the baby and then get kind of stuck. And then another question, and I think you might have touched on this, and I might have missed it. How do you differentiate preeclampsia versus the autonomic dysreflexia?
So with the change in blood pressure for preeclampsia, that is going to be a more sustained blood pressure, versus with autonomic dysreflexia, you're going to see those spikes in blood pressure that coincide with contractions.
And then how do you manage both of them?
So preeclampsia and eclampsia. Eclampsia, you would definitely need to proceed with labor as soon as possible. May require a cesarean section at that point. And then for autonomic dysreflexia, the treatment would be similar to a normal spinal cord injury patient with autonomic dysreflexia. So trying to sit them up, trying to address the noxious stimulus, whatever it may be, whether that is catheterizing them to empty their bladder, ensuring that they have been on top of their bowel regimen, and then more immediately addressing blood pressures with the appropriate medications and topical applications.
Yeah, I mean, it's really tough because, right, you want to make sure the baby is getting perfused, and you don't want to, as soon as that contraction's over, the blood pressure may tank again. So really, the epidural, you know, get the epidural, do the epidural, start that as soon as possible, as soon as you kind of start noticing it. Another question, did you see any literature, are you familiar with anything about, like, do these patients need to be seen by a maternal fetal medicine, or would you just have them with their kind of normal community obstetrics professional?
So I think the consensus right now is that this really needs to be a multidisciplinary approach. So obviously the obstetricians are there because they have the most experience with pregnancy. The physiatrist should be there because they have the most experience with spinal cord injury. The anesthesiologist should be aware of them as well, be on the team as well, because as you said, they need to administer analgesia as soon as labor is identified in order to avoid autonomic dysreflexia.
Yeah, and I think a lot of us would probably start with, like, especially a first pregnancy, with referring to maternal fetal medicine, just because not many, you know, community obstetrics folks really have a lot of experience with this. And not that necessarily everybody who is in maternal fetal medicine would, but I think they might have a little bit more consideration of this. Last question, when would you kind of start the conversations about pregnancy?
So I would start as soon as possible if the patient is of childbearing years. So you don't know, not every pregnancy is planned, and there's nothing that prevents a woman with spinal cord injury from becoming pregnant. So having that conversation very early on, I think, is the best way to approach the subject.
Yeah, especially if they're kind of planning on becoming pregnant, for sure. One thing to keep in mind, patients who are newly spinal cord injured, women who are newly spinal cord injured, they may be amenorrheic at first, but that doesn't, counsel doesn't mean you can't get pregnant, or we don't know when they're going to start. And so, you don't want to have any oopsies or surprises right at the beginning when you're not intending for it. And then there's one exception to kind of the rule, like the babies are fine. There's no real difference between spinal cord injury and non-spinal cord injured individuals, and that's if the person obtains their spinal cord injury while they're pregnant. In which case, there is some risk to the baby in that specific situation. And that's due to extenuating, having to go to surgery, really critically ill at that point. But otherwise, you're absolutely correct. No real difference in outcomes. So again, Emily, awesome job. As long as no other questions, we'll let you go. And again, this will be posted on the YouTube and sent out to the group so everybody can access it. Thanks so much.
Thanks, everyone.